Good day, everyone. My name is Sylvia Omuta. I'm going to be speaking on the topic cholera and C. difficile colitis, but I'm going to be starting with cholera. Introduction and etiology of cholera. Cholera is an acute diarrheal disease with potential for rapid dehydration, World Health Organization 2020. It's caused by Bacterium vibrio cholera. Vibrio cholera, a gram-negative bacterium, serogroup 0,1 and 0,139, are responsible for cholera outbreak, Climate Etoy 2017. Its transmission occurs through contaminated water and food. It is estimated every year that 1.3 to 4.0 cases are registered and 21,000 to 143,000 deaths all over the world are due to cholera 1, according to World Health Organization. Pathogenesis. Vibrio cholera infection ingested contaminated water or food containing vibrio cholera. Cholera toxin production. Bacterium produces cholera toxin, CT, encoded with CTS gene. CT action bind intestinal cell, activating acyclic glycolase, raising count level. Ion disruption. Elevated count disrupt ion transport, causing massive chloride secretion, leading to profuse watering diarrhea. Dehydration and spread. Rapid water loss results in dehydration, and contaminated water source facilitate the spread of this disease. Harrison et al. Species of virulence. Cholera toxins. Structure cholera toxin, a matrix protein with A and B subunits, mechanism of action. Attached B unit binds to this intestinal cell. Entry a subunit, entry the cell, activating aldolate glycolase. Cyclic AMP production results in escalating glycolic AMP level, causing ion secretion and watery diarrhea. Violence and characteristic. Rapid colonization. V. cholera rapidly colonize the small intestine, enhancing toxin production. Toxin dissemination. Cholera toxin secreting, affecting a wide area of the intestinal line, leading to massive fluid loss. Biofilm formation. Vibrio cholera form biofilm, aiding survival and persistence. Disease description. Organ affected and mechanism. Primary impact on the small intestine. Vibrio cholera colonizes intestinal epithelial cells, releasing cholera toxins. Cholera toxin reduce uncontrolled secretion of electrolytes and water. Common signs and symptoms. Severe watery diarrhea, vomiting, dehydration, leading to electrolyte imbalance. Cramp. Disease description. Stages and development. Incubation period 12 hours to 5 days post-exposure. Asystematic carrier stage. Some individuals carry this bacterium without symptoms. Acute stage, sudden onset of profuse diarrhea, vomiting, and dehydration. Prognosis, critical to administer dehydration therapy promptly. Untreated cases can lead to severe dehydration and death within hours. With timely intervention, prognosis is generally good. Transmission. How cholera spread. Focal oral transmission. Cholera primarily spread through contaminated water and food. Feces of infected individuals that contain vibrio cholera bacteria system, according to World Health Organization. Contaminated water source. Ingesting water contaminated with vibrio cholera leads to infection. Poor sanitation. Untreated sewage, contaminated water supply. Key consideration, we have cholera toxins persist in aquatic environment also. Outbreak often linked to contaminated water supply and inadequate sewage system. Treatment for cholera. Rehydration therapy. Oral rehydration solution is a system of treatment. intravenous fluid for severe cases to address dehydration, antibiotic therapy. Diazoxycline or azithromycin might be prescribed in severe cases. Symptoms. Supportive care. Electrolyte replacement to correct imbalance and nutritional support for recovery is advised. Prevention of cholera. Vaccination. Oral cholera vaccines such as Shock and Vascura offer effective preventive measure, particularly for travelers in high-risk population. Water and sanitation. Ensuring access to safe water resources and improving sanitation infrastructure significantly reduce the risk of cholera transmission, according to World Health Organization. Hygiene education, promoting hand hygiene, safety, practice and educate the community of cholera transmission prevention are priority in controlling outbreak. Surveillance and early detection, establish robust surveillance system and implementing early response strategy are essential in time outbreak identification and containment, according to World Health Organization. Now I'm going to be talking on C. difficile colitis, introduction and etiology. C. difficile colitis is an inflammatory condition affecting the colon. It is often associated with antibiotic use and it can lead to severe diarrhea and complications, Kelly and Lemart. It is caused by the bacterial Clostridium difficile. Antibiotic therapy disrupts the normal gut microbiota, allowing the C. difficile to flourish and produce toxic triggering colitis. Pathogenesis. Toxin production. C. difficile produce toxins, primarily toxins A and toxins B. Disrupt of gut microbiota. Antibiotic use disturb normal flora, creating favorable condition for C. difficile. Toxic mediated damage. Toxic cause inflammation and damage of intestinal lining, leading to diarrhea and colitis. Spore formation. Spore formation ensure bacterial persistence and transmission. Characteristics of virulence. Ta10A bind to receptor of colonic colitis, causes inflammation and fluid secretion. TB10B disrupt the actin cytoskeleton of host cells. Spore formation. C. difficile form spores, allowing survival in environment and resistant to harsh conditions. Disease description. Organ affected and mechanism. Primary effect the colon, large intestine. C. difficile spore germinate colonize the colon and release toxins. Toxins and B disrupt the epidermis, leading to inflammation and damage. Common signs and symptoms are watering diarrhea, often occur multiple times a day, abdominal pain and cramping, fever, and loss of appetite. Disease description, stage and development. Asystematic carrier. Some individuals carry C. difficile without symptoms. Mild to moderate infection, diarrhea, abdominal pain, and discomfort. Severe infection, profound diarrhea, colonic inflammation, and potential complications like pseudomembranous colitis. Prognosis. Prognosis varied. Mild case may resolve with appropriate treatment. Severe case can lead to complications including toxic microcolon, requiring intensive care. Reoccurrence is possible, emphasizing the need for care management. Transmission. Fecal oral route. C. difficile is primarily transmitted through fecal oral route, with spores shared in the faces of infected individual. Contaminated surface. Spores persist on surface facilitating transmission through contact with contaminated objects. Healthcare setting. Common in hospital. Transmission occur via healthcare workers' hand and equipment. Antibiotics use. Antibiotic and therapy disrupt the normal gut microbiota, enabling these severely propagations. Person to persons, direct and indirect contact with infected individual transmit spores, including from asystematic carriers. High infection spores, resistant spores survive in the environment, contributing to prolonged transmission. Treatment. Antibiotic therapy, fecal microbiota transplant, supportive care, and surgical treatment are required. Prevention. In order to prevent this disease, antibiotic stewardship, prudent use of antibiotic to minimize disruption of gut microbiota, infection control measures, strict adherence to hand hygiene protocol in healthcare setting, environmental cleaning, effective cleaning and disinfection of surface to prevent spore formation, probiotic, and fecal microbiota transplant is needed.